everybody. Welcome back to another episode of The Skeleton Crew. I'm your host, Jen Callahan, and today I have with me a great guest. It's Dr. Stacy Smith Foley, and she's joining me from a great center that's out in Arkansas called Khatai, and she's here to talk to us today about mammograms and, breast health and breast imaging and everything that goes along with that field there. So, Stacy, thank you for being with me tonight, where I am.
Well, thank you so much for having me, Jen.
My pleasure. So I gave just a little bit background of yourself, but let you handle the ins and outs of your career and kind of maybe how you ended up with Khatai, and then we'll talk about Khatai itself.
Sure. I'm a fellowship-trained breast radiologist. When I was a senior in medical school, I had to decide what field of medicine I was going to select. And I'm very analytical. I made a pro-con list, and it came down to the things that I really liked were procedures, analytical endeavors, but I also still liked patient care. So I was a little bit conflicted when I decided to become a radiologist, because a lot of people think that radiologists don't have direct patient care. However, in breast imaging, you can have all the direct patient care you can handle. Because, as a breast imager, I'm talking to diagnostic patients and I'm performing procedures, and, radiology just seemed to tick all of the boxes. And even from the outset, I knew that I would ultimately go into breast imaging. Just as I started my residency, I knew that's where I would end up. I went to medical school here in Arkansas, at the University of Arkansas for Medical Sciences, and I did my diagnostic radiology residency in Knoxville, Tennessee, at University of Tennessee. And then I did a full year of fellowship as a dedicated breast imager, so a full 12 months in Seattle at the Khatai Cancer Center in association with the Seattle Cancer Care Alliance and the University of Washington. And from there, I made my way back to Arkansas, which is my home state, and I was in practice in Northwest Arkansas for about 10 years. I spent a short amount of time in Tulsa, Oklahoma, where I actually launched the first 3D mammography program in that area. And then I landed in Greenville, South Carolina for a short stint, and I've been back home in Arkansas, in Central Arkansas, which really is my home, for the last 5 years. So 5 years ago in June 2019, we started the breast center here at Khatai.
And so before Stacy and I started speaking, I unfortunately did call it Cardi, and she said it's not Cardi like Cardi B, it's Khatai. So just a little for anyone who does look into this further afterwards, it's Khatai, and she gave me a little blurb behind it that it used to be for radiation therapy, but now they are basically all things cancer, and you're specializing within breast cancer specifically.
Yes. So we're all things cancer. We're a nonprofit, community-based cancer center that's multidisciplinary, and we have multiple different locations across our state. But I am at the flagship. I'm at the main center here in Little Rock, Arkansas, and we even have our own outpatient surgery center. So we're able to provide comprehensive cancer care for our patients, and even continue to care for them as they've completed their cancer journey and they move on to survivorship. We have a whole new service of support services for patients called The Bridge. We're offering therapy, nutritional support, massage therapy, exercise, just all of the things that patients really need to help them through this difficult journey.
Do you find, you might not possibly know this, but do you feel that most patients that are going through treatment with Khatai, that they do actually follow through with the Bridge? Not to say therapy, but, the continuing services?
Well, the Bridge is new. So, we just recently launched the Bridge. I think there's a lot of excitement about it, and I'm actually very excited to be able to, have that resource to recommend to my patients, because I've always said when the bra comes off, it all comes out. Patients are in a vulnerable state when they come to the breast center, and they oftentimes share very difficult things with me. And I feel very reassured to know that there's a psychologist, there's a team of psychologists here
Right.
that I refer them to. I have had a pattern of patients coming into my practice where their spouse was a Khatai patient. Their spouse had cancer. And so they were coming here for their appointments and their treatments with their spouse. And then maybe they lost their spouse. And sometimes then it's hard to come here. It's very emotional when they're coming, even when it's just for a screening, because it just brings up a lot for them. And so oftentimes they share things like that with me. And we have a chaplain on staff. We're able to offer grief counseling and all of the types of, support that cancer patients need.
And that's a great thing to have offered to them, because, you find some people who possibly know that, services like that would benefit them, but they don't necessarily maybe have the stamina to do the research, into finding a therapist for themselves or a chaplain or, someone that they can talk to about their grief that, they don't, not to say that they don't want to do the work for it, but it's just kind of easier not to and kind of sit with your feelings. But here, Khatai is offering this, saying, we've already done this work for you. And here, maybe here's 3 names, 3 doctors that we have that you can call, and that you don't have to do the extra legwork for. And, just a weight lifted off of a patient or even a family member of a patient.
And to have it all consolidated in one location,
Right.
Beautiful. I think if you had time, if you have looked at our website, like one of the things that's different about Khatai is it is a beautiful space. Like the campus is beautiful. We have a grand piano in the lobby, and somebody comes in and plays live music 5 days a week for a few hours in the middle of the day. And like sometimes we even have, flautists or violinists. And in the winter, we have these fireplaces that are going. So it's like, it's just a different type of environment.
Mm-hmm. It's a comfortable space.
It's a space for healing.
Right. Inviting almost.
Yeah.
Right. So let's talk then about, breast imaging, and maybe from the time of when you started in your fellowship and decided that you wanted to do that and, where it currently is now. Have you seen like leaps and bounds in changes of imaging itself? And then, we were talking previously about guidelines as well.
Well, holy smokes. I mean, when I was a resident, they still had film screen mammography with all of that QA and the pick off and, thumbprints on images that were artifacts that could get a patient called back. By the time I was a senior resident, we were transitioning to digital mammography. So it was, there were 2 different types there was computed mammography and then there was digital.
Mm-hmm.
And I think we might have had computed in the beginning. So it was a digital image. We were no longer looking at the mammogram on a film. We were looking at the images on a monitor. And when I came out of fellowship, at the time, the percentage of facilities that were quote unquote all digital was less than 10% across the nation. And that was in 2006.
Mm-hmm.
So, around, 2011, we saw the advent of digital breast tomosynthesis. And in the beginning, there were a lot of discussions at meetings like, does this really benefit patients? There were discussions that maybe we couldn't see calcifications as well.
Mm-hmm.
So that was something that kind of held me back from jumping into that technology, because I'm really good at I'm a spec finder, I'm good at finding calcifications, and I didn't want to miss the opportunity to make an early diagnosis if the technology prevented that. So, I was in private practice at the time, in a practice where we had to purchase the equipment ourselves as our business. And so we did not just jump right into Tomo. We knew that we were missing cancers because of dense tissue, like even back in 2013, 2011, 2013. In my practice, we were very aware that the patients that we failed were the patients that had genetic predispositions and those who had extreme breast density. And so we were very early adopters of whole breast ultrasound screening.
Okay.
And we embraced new technology called SonoCine. It was a articulating arm that worked with your ultrasound transducer, and it allowed the technologist basically to take cine loops of the entire breast, and you watch them back like a movie. So I have long felt that learning that technique, like adopting that technology, sometimes those exams would take like 5 to 10 minutes to review, but looking for that blip of the abnormality coming in and out of focus, it's almost like it prepared me for tomo.
Okay.
Because when you're looking at a tomo stack, you're looking for that thing that shouldn't be there, like that thing that disrupts the flow. And so we didn't, in our practice at the time, we didn't get tomosynthesis in our technology until about 2016.
And just to clarify, for those who are listening, and just for myself, tomosynthesis is kind of what you would say in lay terms is like 3D imaging.
3D mammography. I think what a lot of people, even people in the field of radiology who don't do mammography, what they don't realize is tomosynthesis is almost like taking a mini CT of the breast, where you're taking all these different slices and then they're put together with computer software to generate, an image. In our practice, we no longer do the combo mode where you take 2 images. When I started the practice here in 2019, we went full in with high-res 3D. And so from the very get-go, we started doing the technique that reduces the radiation by 40%. Because the newest software and the newest equipment, the quality of the images is so good, you don't need that extra picture and that extra radiation. But, in the 5 years since we started this practice, I've seen definite the advances that AI, so many different AI platforms coming in. Another kind of technological advance that we were very early adopters of was something in ultrasound called shear wave elastography that can help you discriminate between benign and malignant lesions.
Okay.
I find I speak about that a lot because I find it to be a useful tool. And
is that to show like different like blood flow to something? Like how would it differentiate the two?
It shows stiffness. So it shows in a color map, and it shows areas that are more stiff than the tissue that surrounds it. So it's not just how stiff it is, but it's also the pattern. Like normal breast tissue is homogeneous and soft versus a malignant lesion that's heterogeneous and stiffened.
Okay. All right. So then it shows the edges of that. And that saves a patient from having to have a biopsy done of the area.
Yeah, it can actually. So when you're in mammography, we have the BI-RADS categories. And if we have a lesion that we're on the fence, like, does this need to be biopsied or can it be followed? Sometimes, the added advanced tool of the elastography gives us more data to say, no, this one needs to be biopsied, or, I feel really confident that this isn't breast cancer and I think it would be safe to follow it.
Mm-hmm.
So it helps you upgrade the cancers that you might have a delay in the diagnosis because you're just following them. And then it helps you downgrade some of the benign lesions so you don't have to biopsy as many benign lesions.
And now you were discussing about, so many different AI platforms out there. And Stacy and I were speaking about this before we started recording. Is that something that Khatai uses at all to help with, especially for the dense breast imaging?
So yes, we do have an AI platform that we use a couple of different AI tools.
Okay.
We have an AI tool that does automatic breast density assessment. Now, some of those, there's lots of software that does that. And, I think in the beginning, I was resistant to that, additional software package because I felt like I'm a pretty good breast radiologist. I know which breast is dense and which breast isn't dense. But I find that it helps support the decision that I'm making when I'm looking at the image. And now that we have new regulations around breast density notification that are going to be across the country, uniform in the fall, I think it's even more important to be consistent with that. One software, AI software that's a breast density assessment, but then we have a computer-aided detection tool as well that, helps tag areas that are more suspicious. It even puts into an order of importance which cases you should maybe look at first, and even tells you like, how is this going to be a fairly straightforward case before you open it, or is it going to be a more complicated case?
Mm-hmm. And the great thing about all the AI tools that are offered out there is that at the end of the day, the radiologist has the final say, so, you can take what they're suggesting, and like you said, sometimes it, it helps you and to reaffirm what you already feel, or for you to be like, no, I don't believe that that's it. I feel like with so many AI things coming out with computers and stuff, people are like, oh, like technologists and radiologists, one day they'll be obsolete, and,
Not, not be obsolete, because who else can perform the biopsy? We're the only ones who can perform the biopsy, and we're the only one who can hold the patient's hand and talk them through the process. So, I see these things as tools in our toolbox,
right,
that can help us be better at what we do. And maybe they help us make a more confident decision so that we can spend more time with the patient,
right,
communicating directly.
Mm-hmm. So let's continue on with, things that have been changing. You were talking to me before, and I also too saw on your LinkedIn that you had shared about the breast screening guidelines changing. So currently right now, it's age 40 that is suggested that you should have a breast screen. Are they changing, that they're lowering the age at this point?
So if you go back several years, you will find that the United States Preventative Services Task Force really muddied the waters and made things so confusing for patients when they changed. They are the ones who changed the guidelines. The rest of us have always had the guideline that, like anyone who has any focused, practical medical application in the breast cancer field, we have always recommended that average risk women start screening at age 40 and that they screen yearly. But the Preventative Services Task Force changed that some years ago, and they said, oh, women can start at 50 and they can go every other year, and then they can stop at 75. And, the result of that has been that more women are more women are skipping their mammogram. And of course, COVID didn't help that at all.
Right.
I think if we give people an excuse, they'll use any excuse not to get their mammogram. But I think the result of that is we are finding that women are coming in with more advanced disease because they didn't start screening earlier. The data is also showing that it's not just breast cancer, it's all cancers, that even younger people are getting breast cancer, or people are getting not just breast cancer, but people are getting cancer at a younger age. Mm-hmm. So because people are getting a cancer at a younger age, we do have to adjust the guidelines. So the task force did a good thing. They realigned, they course corrected with the rest of us. They're now recommending that average risk women start at age 40, but they continue to recommend every other year, which is not adequate. A woman's mammogram can change dramatically in 12 months, and, so can her health. So I still think it's very important that women screen every year. They have said that women can stop screening at age 75, but the data says that a woman continues to have a risk of breast cancer as long as she's living. If we look at the curve kind of plateaus when a woman is between the ages of 80 and 90, but it's not because her risk for developing breast cancer decreases. It's because women in that age range start dying from other.
Wow, that makes sense.
Right. So, I have what I call my collection of my golden girls, and they have one really important thing in common. They have all come to me. These are like women I've diagnosed with breast cancer between the ages 80 and 95.
Wow.
What they have in common is people stopped telling them to get a mammogram, and even told them that they didn't need to get a mammogram when they were otherwise healthy. So when they came to me feeling a lump in their breast, they had a larger cancer, a more advanced cancer, a more aggressive cancer. So if they had been screening on a yearly basis and they had been screening continuously, their cancer could have been detected at an earlier stage for sure.
And does you wonder why, why the recommendation is to stop at 75? Because like you said, it doesn't mean that you still can't develop some type of disease that, is it because the life expectancy is maybe at that around that age?
Life expectancy of an otherwise healthy 75-year-old is
Yeah.
to 10 to 15 years. So, like even if you looked into the guidelines based on life expectancy, that guideline was if you have less than 5 years to live. Now, obviously, you have to put this into the context of the individual patient.
Mhm.
Say if you have a patient with severe dementia who doesn't really know what's going on, and it's going to be like physically challenging and or mentally challenging for her to have a breast exam, and her life expectancy is less than 5 years, then maybe that's the patient who doesn't need to get a mammogram. But my mom's 75 and she's very vibrant, and she better get her mammogram or I will be all over her case. And she does. She gets her mammogram every year. She's a very consistent patient.
That's good. So for women who do have, kind of like genetic markers or, it's in their family history, should they actually have screenings done sooner than age 40?
They should. And there are a few things that the task force really missed the opportunity to deal with. One of those is family history and genetic predisposition. The Society of Breast Imagers actually recommend that all women have a conversation with their primary care provider by their 25th birthday, right? So that they can discuss their family history. And the goal with that is so we can identify those women who are at the greatest risk and we can start screening them sooner.
Mm-hmm.
And we can offer them options like genetic testing. If, genetic mutations only account for about 5 to 10% of breast cancers, but those patients have the highest personal risk. So we really do need to find them, we need to start screening them early, because when they do get cancer, it tends to be more aggressive. It tends to be, triple negative, much harder to treat, and it tends to grow quickly. So, for those women, when they've had that risk assessment by the age of 25, if they're found to have this elevated lifetime risk, we can start doing MRI on them between the ages of 25 and 30, and then maybe add mammograms in at age 30. I have what I call the 10-year rule of thumb. So, whatever your family history is, you should consider starting to do screening tests about 10 years before the age the youngest person was diagnosed. So if your mother was diagnosed with breast cancer at age 40, we would want you to start getting your mammograms at age 30.
That's smart. It makes a lot of sense because the mother who possibly had it at age 40, maybe she didn't catch it until, it's more advanced. So if you follow the 10-year guideline, you can catch it quick.
Mm-hmm. Another thing the task force failed on is they really didn't address 3D mammography. We have so much data that shows that 3D mammography does two things that are, very rare for a screening test. So the tomosynthesis, the 3D mammograms, we find more cancers, but we also have fewer false positives. So we call fewer women back unnecessarily because we can determine with the 3D image that that's just normal tissue.
Is that not something that's normally used? I hate to say that, as a X-ray technologist, I don't know the ins and outs of mammography and, the different screenings that, or I should say maybe the different types of imaging used for it. I've heard of 3D breast imaging, but I've seen we offer that here at this location. And I kind of would have assumed at this point that that's just something across the board that's offered to patients, but is it still?
It's not offered universally. I would say probably the majority of the mammography units across the country do have 3D capabilities, but not all patients. You still have some centers that have some older equipment that's viable. And so maybe not all of their mammo units offer 3D, so they may have to triage.
Mm-hmm. So centers that do have it, though, say, for instance, like Khatai, you have 3D imaging. That's just every patient receives that type of imaging.
It's standard of care here.
Okay.
That's not universally true. You just can't expect that. If you want to make sure that you're getting a 3D mammogram, you need to be asking that question.
Okay. Gotcha. Even for like places that do have it, they just might not offer it to you. That's interesting.
Right. Because not all of their mammogram units may have the capability.
Right. Okay. Maybe they reserve that for patients who have
dense tissue or patients with dense tissue, which is another area that the task force failed. So the task force said nothing about women with dense tissue and supplemental screening. And we know the data is robust that women who have dense tissue have an increased risk of developing breast cancer, and that is an independent risk factor. And the only way to mitigate that risk is with supplemental screening. And the options for supplemental screening, the most available options for supplemental screening are ultrasound and MRI.
Mm-hmm. And now when you were saying for patients who would start having screenings done earlier, that you would suggest starting with MRI, is it just for the radiation portion itself that
it's somewhat for the radiation, but the MRI is our best test. Okay. It's our best test at detecting breast cancer. So if a patient has a defined elevated risk of 20% or greater lifetime, then the MRI is the best test. And I'd want to start with the best test.
So much information, I'm sure, flying around, for radiologists and even technologists. As a technologist myself, I know that we're required to do continuing education every 2 years. Is it the same for radiologists, with all the new information that's out there for breast imaging and, all the different types of equipment and AI? I'm sure sometimes your guys' head just like explodes.
Well, if you're board certified and you're maintaining your your maintenance at certification, we're required to have 25 hours each year in radiology specifically, and they can do an audit, and what they're looking for is, have you had 75 hours over the last 3 years? There are lots of good options these days. Sometimes it's industry sponsored webinars that are available free of charge. I favor the in-person meetings. I really enjoy attending the Society of Breast Imagers meeting when I can. I try to go most years because it's just such an uplifting opportunity to be with my colleagues, to be with people who are like-minded and who are as passionate about the field of breast imaging and breast cancer detection.
So speaking of being passionate and, sharing the word of breast imaging, and I don't really know how else to go into this, but Stacy and I were talking earlier about how she is a TikToker, not to even be funny about it, but, just to put the good information out there for patients who, you might feel uneasy about it or you're unsure of exactly what you're doing. But Stacy, just explain what we were saying earlier about, your 3 different videos that you were doing. And, she's kind of a sensation at this point in the world of breast imaging.
Not really a sensation, but my surgical colleague and I, Dr. Yara Robertson, we have a collaborative TikTok account that is Breast Friends, the number 4, Emma, and forever. And we've been making TikToks over the last at least 3 years. And the reason we started making TikToks is we found that is where people were seeking information.
Yeah.
And we looked at some of the information that was available, and so much of the information was misinformation, myths. There's a lot of information out there warning women, telling them not to get mammograms. I had a patient recently that refused the mammogram, and this is why she told me, I'm going to quote, because they've been banned in Switzerland because they're so dangerous. Apparently that's a thing. That's a big myth on the internet out there. But we started this collaborative TikTok account, this social media engagement with patients to try to bust the myths, to try to provide good advice, to educate patients, to give them recommendations, and also to kind of show our personalities and to make it a little less scary. It's kind of scary thinking that, oh, I'm going to go get my mammogram at the cancer center.
Right.
Like that is a scary word. But if it's, I'm going to go get my mammogram at Khatai with Dr. Smith Foley, she does those cute TikToks. She seems so fun. That it's more approachable.
Mm-hmm. Mm-hmm. The one that I saw that they just put up recently that I was talking about, she did share that it's hit a good amount of views, but just, basically explaining when you're going in for your mammogram, what you should and should not do, and, how to prepare yourself adequately, which, I mean, as a technologist from X-ray, the first part of it was, what should you wear? Should you wear a dress or should you wear a two-piece outfit? And I feel the same way that, how you explain in it, that you should wear the two-piece so you can just take your shirt off instead of having to take your whole dress off.
Right.
And I kind of feel the same way about, as technologists, for a patient who's coming in for just a quick chest X-ray, but they have this like elaborate bra and there's all these necklaces on it, for simple things like that can just easily break it down for a patient who, is going out for the day, and, maybe you don't have to look your best and wear your prettiest dress, to go in something that's more easily to take off to prepare yourself for your imaging. Do you want to share any more about that video, about, how else to prepare to come in?
Well, I think one of the other things that we reminded patients is we don't want them to wear deodorant or lotion because it can create an artifact that could mimic calcifications and could maybe cause the patient to be called back unnecessarily. The other things we touched on were that if you experience a lot of discomfort with your mammogram, you can take a couple of over-the-counter pain relievers, 30 to 45 minutes before your exam. And that might help with some of that discomfort that some women associate with getting the mammogram. I would say pain and fear are the two things that prevent women from getting mammograms.
Sure.
And for the women who are younger, who still have their menstrual cycles, I would recommend that you not schedule your mammogram at the same time as your menstrual cycle. You're going to be more sensitive in that time frame. And so the mammogram might be a little more uncomfortable.
And that was a good one. I did see that at towards the end. I mean, it makes a lot of sense and it's just simple things that you don't necessarily as a patient think about. But definitely is leading up for the 1 to 2 weeks prior to your cycle that, your breast might be tender and, you don't really want it being squished between something. So, that's I feel like that's a huge recommendation that many might not have even thought about.
But I would also say the caveat to that is there's no perfect time. It's kind of like Nike with the sneakers, just do it.
Yeah.
It's better to do it and not do it at, and it being an imperfect time than to put it off and to not get it done.
I find it interesting that how you had said the deodorants, which I did know that deodorant shouldn't be worn for it, but I have to say that I did not know that lotions was one of something that you should not have on prior going to your mammogram.
Lotion and talcum powder. One of the things that can create what I would call a crazy artifact on the mammogram is, some women will have a lot of issue with like moisture and yeast but below their breast. And sometimes they'll use ointments that, like A&D ointment or like Boudreaux's paste, those types of things. And those types of ointments have silica in them, which creates a crazy artifact and makes it look like they have crazy calcifications in their breasts, and they don't. It's an ointment. And, like the clinical strength deodorant, that stuff it's semi-permanent. It gets in the pores and it's hard to get out. So if you use that kind of deodorant and it's caused a problem on your mammogram in the past, you might want to not use it for about a week leading up to your mammograms.
Oh, wow. Maybe even exfoliate that area. Maybe it would help clean.
Not a bad idea.
Yeah.
Bad idea. But if you're using that A&D or that Boudreaux's paste, for the moisture issue, sometimes we'll have those people come back in a few weeks, stop using it and come back in a few weeks. One of the things that can happen if a woman is having irritation under her breast, she could have a skin tear when she has her mammogram. And it's not tragic, but it's really uncomfortable. It's uncomfortable enough. Like, can you imagine the worst paper cut you've ever had, but it's under your breast? Like, again, it's not tragic. You can usually put some Vaseline on it to make, to keep it, to help it heal and to make it a little more comfortable. But if that does happen, when you take a shower after your mammogram, it's like shocking because it's so, just imagine like the worst paper cut of your life under your breast.
Yeah.
So if we have a question on our questionnaire, we ask women, have you ever had a skin tear? Because we want to know that in advance. And if we've ever had a patient that has had a skin tear in the past, we notate that. So we'll be mindful of it. But there's some things that we can do. We have these coverlets that can go on the mammography machine. That's a barrier between the machine and the patient's breast. Okay. And so in the summer, when women are hot and sticky, there's, a greater likelihood of that skin tear. And so we try to use the coverlets really all the time. But those are some things that we think about when we're bringing the patient, when they're bringing the patient back and they're going to go ahead and perform an exam.
Would you find that maybe patients who maybe with thinner skin, possibly older patients who have
patients who have heavy pendulous breasts are more likely to get a skin tear as well.
Yeah, that sounds extremely uncomfortable. I couldn't imagine that. I thank God I don't have large pendulous breasts. So looking forward, with Khatai and the bridge and everything, any other great developing news, for the center?
For the center, well, I think we'll be opening our 5th location in the next year, which will bring mammography services to South Arkansas, where they're sorely needed.
Well, that's good.
So that's something exciting that's on the horizon. We've just gotten another 3 Tesla MRI unit at one of our locations in North Little Rock. And so we've opened a breast MRI at that site. So we now have 3 sites that are offering breast MRI. And we have a high-risk clinic with a nurse practitioner and genetic counselors. So patients can self-refer, so they can have that risk assessment and they can learn if they're at a higher risk. They can undergo genetic testing, and then they can be seen in that clinic, and they help manage their recommendations for screenings, even beyond breast cancer. But having more locations to offer MRI is definitely a benefit, because that's a bottleneck. I said in the beginning that it was, it's the best test. And some people might ask, well, why don't we do that on everybody? There's not enough equipment for that to be the standard screening test. And so because we do have a high population of the high-risk patients, it's been a bottleneck in our practice. So we're excited that we'll have more opportunities for patients to get their MRI.
Right. And like you said, with the new location where it's coming, that there's not much imaging centers, it's something that you kind of take for granted sometimes, at least for myself, that, I live in the Philadelphia area and it's so heavily populated, and I feel like there's imaging centers everywhere. And we have like 3 large health systems that, are just vastly, I feel like if you need an appointment, you can probably get an appointment. And as long as you're willing to drive maybe an extra like 30 minutes or so, you can probably easily get an appointment within like a, week, 2 weeks or so. And it's something that I hate to say that at least myself, takes for granted for living in the type of area that I do. You don't think about patients or people that live in areas that are less populated, that services like that aren't easily
accessible.
Right.
Arkansas is a very rural state.
Yeah.
So, we have a concentration of our population in Central Arkansas and Little Rock, and in Northwest Arkansas and Fayetteville, Bentonville. But otherwise, we're kind of spread out. Mm-hmm. And so it's not uncommon for a patient to drive 90 miles each way to come and see me, or to drive 2 to 3 hours each way for their mammogram, because there aren't quality services or specialists available to them. So one of the missions of Khatai has been to bring care to patients in their community, because we know that patients, they do better there. They get through their journey better when they're able to stay in their community and they're able to be supported by their friends and family locally.
Mm-hmm.
So we're
Do you have radiologists on site there then? I mean, are they considered outreach sites? Okay.
Yeah. So, we have an outreach site in Pine Bluff, Arkansas, which patients who are less advantaged to some extent, it's a completely different demographic, definitely at-risk patients, but it's a smaller center than the big Khatai Cancer Center in Little Rock, but we have a breast radiologist on site there. We have 3D mammography, we have ultrasound, and we have MRI there, and we offer stereotactic ultrasound, MRI biopsies. So it's comprehensive care in their community.
Right. That's great. That's amazing. Khatai seems like an amazing place, for patients, past, present, future, and even the families, like how you had said that, so many people encompassed in care for the patients, So thank you so much, Stacy. I really appreciate you being with me tonight. Everybody, this is Dr. Stacy Smith Foley talking to us about everything breast imaging and the great Khatai out there in Arkansas.
Thanks, Jen.
All right, everybody. We'll see you next week. Make sure you check us out on YouTube, Spotify, and Apple Podcasts. So, all right, we'll see you later. You've been watching The Skeleton Crew, brought to you by xraytech.org. On the next episode, join us to explore the present and the future of the rad tech career in the field of radiology.